Thank you all for listening to me, and thank you, Tim, for inviting me to speak at this session. It's a great honour, and I'm learning a lot from others that have spoken before me. So, as mentioned, I run the clinical registry unit at Monash University, and for nearly 10 years now I've been leading the prostate cancer registry, which started as a pilot in 6 hospitals in Victoria and then went national in 2012, and then last year we the Data Coordination Centre for the Global Prostate Cancer Registry, which will collect a minimum data set from 13 countries and over 200 sites. So it's growing, it's really exciting. So I'm here today to talk about the clinical registries and how they're built and what they do. And Monash has been running them for some time now. I joined, oh my goodness, it's kind of reformatted, sorry. I joined the Monash in 2007 and started the prostate cancer registry in 2008. But before me came the trauma registry, which had been going for some nearly 8 years prior, and a cardiac registry as well. So there certainly was some work that I was able to build on in developing the prostate cancer registry. But one of our first tasks was with the Australian Commission on Safety and Quality in Healthcare to develop operating principles for quality registries. So they were endorsed by the Australian Health Ministers in about 2009, and they're on the Australian Commission website. If people are interested in setting up a clinical quality registry, then I'd encourage you to have a look at the operating principles. They certainly will give you some tips on how you should do that. And subsequent to me building and starting with a team to build the prostate cancer registry, there have been quite a number of other registries that have come on board. More recently, some lung cancer registry, the upper GI cancer registry, and New South Wales is joining us as we're rolling out pancreatic cancer registry over the next 3 years. So we have 25 registries in Monash at the moment, and we're the largest centre. So what are they? So quality registries have been set up. They're not incidence registries, which would take notifications of diseases like your Cancer Institute or our Victorian Cancer Registry. They build on that. So once somebody has been diagnosed with a cancer, they are able to find their way onto our registry. We use an opt-out consent model, but the purpose of the registry is, first of all, we monitor the patterns of disease and treatment and outcomes following diagnosis. We use that information to benchmark quality of care based on quality indicators that are developed by clinicians. And importantly also, registries unashamedly provide an incredible data set to be used for further research. So registries have been set up with a defined minimum data set. We spend a lot of time working out what the data set will look like for our registry. We very much, for all our registries, focus on a parsimonious data set. So we try and keep the data fields as few as possible, because we know that every data field that you add to a minimum data set is the nail in the grave of the registry. And it's costly to collect data, and as soon as you get lots of data fields, you'll end up getting a reduced quality of data in them. So we spend a lot of time developing the data set, and we ask that all hospitals contribute data to this minimum data set, where it can be used to provide benchmark reports, which we send out to hospitals. So it's got a governance process that sits over the top of the registry, and a lot of quality control that sits underneath and makes sure that the data that goes into it is of high quality. So the course of developing a registry does differ a little bit, but usually they come about because the clinicians approach us and say we want to build one. It's usually driven from the ground up, and I think that's the way it ought to be, because there's usually an enthusiasm to make it work when it's driven from the ground up. The biggest challenge in the initial stages is trying to get funding to build registries, and we are quite unashamedly lobbyists for building and maintaining registries, working through government, through philanthropy, and through other kind of funding sources, including private health insurers and hospitals. The Prostate Cancer Registry, we're very grateful for the funding that's provided from the Movember Foundation that sets up the central and reporting and the central registry hub, but our hospitals are generally paying now for all the data that's collected. We charge a small amount of money, but they get such good return on investment that they are providing those funds to us in Victoria. So clinicians get round the table, develop the quality indicators. We use an opt-out consent model for all our registries, and about 2% of patients will opt out of the registry, but we get data collected on 98% of our population. The next task when the stakeholders get together is to determine what those quality indicators will look like. And we develop those as we're developing the data set. So if there are data items that are included but don't form part of the data set, then we'll be asking why. And then, of course, the challenge of ethics. And I certainly sympathise with the speaker this morning that said about 10 months. I think it's a terrible system. Both Victoria, New South Wales, certainly around Australia, things need to get better in ethics. The steering committee will consist predominantly of clinicians. More than 50% will be clinicians, but other stakeholders on the steering committee will include consumers. We have a number of consumers on the steering committee. We don't just have one. And the funder would normally sit on the steering committee as well. And then we have that meeting not terribly often, probably every 6 months, but the operations committee meets every month. So registries work by, first of all, identifying what good care looks like, collecting the high quality data, making sure that there's no cherry picking. So incidence data for cancer is used so that we know that we're not missing some patients that might have been diagnosed but maybe didn't have such great outcomes, and then providing feedback reports to the clinicians. And we know that if you've got clinician support, clinician leadership, and you can provide the data back and stand behind the data to vouch for its completeness and its accuracy, then you'll change practice. In prostate cancer, we looked at the different dimensions of quality when we were building the quality indicators. These are some of the reports that are coming out of them. We're building more reports as time goes on and becoming much more aware that we need to do better in the radiotherapy space. But importantly, this is what is so fundamental to a registry, that you've got this data spine, you collect it from everybody, it's minimal, the data fields have got to be epidemiologically sound, so reproducible. If you get somebody to go in to collect the data after the first person, they're going to collect it the same way, so it's got to be reliable. We collect identifiable data because we want to be able to link it to death registry, we want to be able to link it to biomarker, biobanks, and other areas, and consumers are not adverse to that. We need to be able to collect the fields so that all our outcomes are risk adjusted to adjust for factors over which the clinicians have got no control. So we need to be able to adjust for that in our reports that we send out, and then we send them out, and acknowledging that we have got a minimum data set, but that we can build on that with our ribs for other projects that might be required. So if somebody has funding or would like to put in a project to use our data spine to look at something more, then we would do that on a project basis. So we see that there's value to registries from a number of different stakeholders, from the clinicians because they want to know how they're performing relative to their peers, they want to be able to learn from best, and they also want to look early warning systems in case there is something that's going a bit amok. The funders are interested in it because it gives them some accountability for the care in their services. It also helps with policy development. A lot of the patterns of care and patterns of treatment has changed for prostate cancer, and they can keep abreast of that. The colleges are interested in registries because it provides their clinicians with CME points. More recently it was, well, in the past it was just participating in the registry that would earn CME points, but with the surgeons now there's got to be an audit component, independent audit component in order to get their results, which we think is terrific. But it means that just providing those reports back and reflecting on them at an individual clinician level is not sufficient. They need to have a mechanism to be able to communicate that within their group, and we also have developed a clinical quality of care committee so that if there are outliers, there is some discussion of outliers by that group. And obviously researchers, we find it important because we can look at all sorts of things. So this is just a couple of things that we get out of the registry, and I won't focus on detail, but we have found that when looking at the whole data set from 2008 to 2016, we can look at different kinds of pattern and treatment that's happening amongst the different risk groups for prostate cancer, and we can identify who's presenting with low, intermediate, high-risk disease according to geographic region, according to whether they've been diagnosed in private or public. We have 82% population coverage in Victoria at the moment, and we'll get to 90% by the end of the year, which is our target. Nationally, some states have got very good capture and are up to 100%. New South Wales is a little bit behind at this stage, but we're hoping that as they get some momentum, we'll get them up to 90% in no time. It's run out of the New South Wales Cancer Institute in New South Wales. So these are the reports that we're sending back in Victoria. They're funnel plots and they give confidence intervals. So everyone participating, we send back clinician reports and we send back hospital reports. So clinicians will have their own dot and hospitals will have their own dot. That was all right to start with, but what the clinicians were asking for was, am I getting better or worse? And they'd have to get their funnel plots out and compare it over time with previous reports. They've asked for more sophisticated time series analysis, which will show whether they're improving or not. The top one was where we came from initially, which was basically just every month plotting, but we're now moving to a VLAD system, or adjusted, observed over expected. The reports get fed back and there's activity happening locally. An example of one site had to stop operating, was not getting good outcomes, stopped operating, did quite a lot of adjustment to their service delivery, started operating and have had good outcomes since. It's highlighted regional disparity. I think somebody this morning was mentioning that people in regional areas don't do so well. We found that men in regional areas get diagnosed later and don't get treated. So there's been a big amount of work that's gone into improving that, setting up MDTs which didn't exist, and a care coordinator's been employed to be able to make sure that each man coming through gets a coordinated care service. In the years from 2009 to 2013, we've seen a fourfold reduction in low-risk men getting surgery. Now, that can't be attributed entirely to the registry because there's been a lot of research that's come out as well. But certainly anecdotally, and we've presented back to the clinicians, they get the names of the men in the low-risk group that had surgery, and they've certainly been able to use that and found it useful. So we have seen, and that continues to drop, and we've had a 50% reduction in positive surgical margins. Editorial to follow the journal article that was published last year, middle of last year. And in terms of platform for research, I can't underestimate how important it is. I mean, we've just developed a lung cancer prognostic model. I stuck that one in because somebody talked about that this morning. Using the registry data, validated it in a number of different sites. And we're just about to publish a paper which is going to be quite confronting. One of our registry rib projects looked at ongoing active surveillance for men in low-risk groups. And we've been advocating for men in low-risk groups to have active surveillance, but what we're finding is that many of them are not getting followed up effectively after they go on active surveillance. So there's going to be a little bit of a bit of work that needs to be done for that one. As I say, we've gone a long way. We've got global registry now, including 13 different countries. That's an earlier slide. It's grown. It's about 190 sites coming on board, and a number of clinical trials, particularly in advanced disease now, that have been started up. We all know the challenges. They're challenges that exist in all research activity. Certainly data burden, not being able to do linkage easily, making sure that we've got good quality control. All these things are expensive and not possible in lots of registries that are not adequately funded. But I think that probably if you can get your clinicians behind you, they will make sure that engagement happens. We've had, in Victoria, we've had one clinician not participate, but all our other clinicians, urologists and radoncs have contributed to the registry and will get their reports. That's it. Thank you.